Hi, welcome to World Menopause Day 2023. Really excited that you're here joining us today because we've got a lot to talk about actually. I'm Dr. Louise Newson, a GP and menopause specialist, and we're filming from here in Stratford-upon-Avon where our clinic is. Rebecca Lewis is another GP and menopause specialist who many of you hopefully will know, who co-founded the clinic and the Balance app with me, and also our research and education. So we've got a lot to talk about over the
next... Yes, we have, haven't we?
We'll talk for about an hour. Just really, we thought, obviously, the big focus this year has been on heart disease, but I thought for those people who might not know much about the menopause, we'll just start talking about the menopause and then we can go forward talking about heart disease as well. So what is the menopause?
Well, the menopause means the Greek, meno, month, pause, to stop. So it's actually defined as a year after your last natural period. So you kind of have to wait a year to make a diagnosis that happened a year before. And the problem is, the reason that we get symptoms is that the ovary stops working and it declines in its function, it declines and it fails to produce the ovarian hormones, estrogen, progesterone and testosterone. And when we lose these hormones, it has effects all over the bodies because the body has receptors to estrogen and testosterone and progesterone all over the body. And these hormones are really vital in managing meaning and keeping the organs functioning properly. So people can have multiple symptoms affecting them from the brain right down to the toes. It affects literally every organ. And so that's what menopause is, and the perimenopause is the time leading up to a woman's last period, and that is when the ovary is still functioning but not perfectly, so it starts to fail. It's not failed completely, so women are still having their periods, but their hormones start to decline, and it's rather a stuttering stop as the ovary gradually declines and fails to produce any hormones at all in the menopause, or very low levels. And the problem with the perimenopause is we have really fluctuating levels of estrogen that you can have very high 1 minute and very low the next day or that evening. So it's a very high-low time of estrogen, but overall the levels of estrogen begin to decline, and that's when women can first start to develop symptoms. So for the average age of the menopause in the UK is 51, the perimenopause can precede that by 10 years, so it can often happen in a woman in their 40s. Early menopause is when you go through a menopause under the age of 45, and a premature menopause or premature ovarian insufficiency is when you go through a menopause under the age of 40. Now this is not that rare actually. We think about 3 in 100 women will have an premature menopause naturally, and some women will have a menopause due to medical procedures, treatment for cancers, chemotherapy and radiotherapy can damage the ovaries at any age and cause menopause, or obviously a surgical menopause when the ovaries are removed for cancer treatments or treatments such as endometriosis, for example. So I think that sort of includes all the range of menopause and ages.
So a lot of people think they have to be a certain age, or they have to have certain symptoms, or they have to have stopped their periods before even talking to anyone about any hormonal changes, which actually isn't right, because we know the sooner people can get a diagnosis, the sooner then obviously you know what's going on with you, but also you can think about treatment options as well. And Rebecca's already said we have cells that respond to these hormones all over our body, so when the levels fluctuate or reduce, that can cause a myriad of symptoms. Everybody talks about the flushes and sweats, but they're not the most common symptoms actually. Looking at the symptoms that people monitor through the Balance app, we find that the commonest symptoms are memory problems, anxiety, low mood, poor sleep, muscle and joint pains, reduced libido, skin changes, skin become dry. But also the heart, we have receptors lining the blood vessels, but also actually in the heart, the way our heart functions. We've got a conducting system in our heart, so most of us have very regular heartbeats. If you take your pulse, it's very regular. But if our heart skips a beat or becomes irregular, you can get this fluttering sensation in the chest, which is known as palpitations. And they can be very common, can't they, during the perimenopause and menopause?
Yeah, I think it's a really common symptom. I remember before not knowing much about menopause as a younger doctor, and women were constantly coming through with palpitations and ended up having referrals and 24-hour ECGs. And actually looking back, I sort of shudder to think really, but I think a lot of them were due to their menopause. So in fact, we know from a survey we've done, I think 66% of women coming to our clinic actually suffer with palpitations, but once they get on the right treatment and their hormones are replaced with HRT, that halves within 3 months. So palpitations are very sensitive to estrogen levels and can settle quickly if it's due to the menopause.
And it'd be very frightening, actually. About 5 years before I was diagnosed with the perimenopause, I experienced some really horrible palpitations, and yes, I went to see a cardiologist, and yes, I was wired up. I had an echocardiogram. I had a 72-hour tape where it measures every single heartbeat. But actually, the worst time was like 3, 4 in the morning. It would sometimes wake me up. I'd feel like my heart, because what happens is you often have a long pause and then a pulse, a heartbeat, and it really feels like a thud in your chest. Very disconcerting. But actually, we know the early hours of the morning is when estrogen levels are at their lowest.
Yes.
So it can be very common that people get palpitations. If they occur, without any chest pain or shortness of breath, often people say they don't get them when they exercise. These are all signs that they are what we call benign palpitations, as in they're unlikely to be related to heart disease. And of course, if people do have palpitations and are concerned, you should always get your heart checked out. But we do often see that people, like Rebecca said, once they're on the right dose and type of hormones, their palpitations really do reduce. And it's important to know that as well. But as well as symptoms with the perimenopause and menopause, as physicians, obviously we worry about future health. We want to reduce diseases. Now, most people don't actually realise when they've done surveys that cardiovascular disease, so that's disease associated with our heart and our blood system, cardiovascular disease is the commonest killer worldwide, actually. It's high up there with dementia. Far more common, actually, than all cancers together combined as a cause of death. And when people are surveyed, people always think it's breast cancer is the commonest cause of death in women, and it's not at all. Actually, it is heart disease. And when I was at medical school many years ago, I was taught that women had a lower risk of heart disease than men, which is right. And I was also taught that over the age of 50, this difference between men and women really narrows, which again is right. What wasn't right is that I wasn't taught the reason for that. And the reason is because when people are younger, we have estrogen that protects our cardiovascular system. So estrogen and testosterone and progesterone actually are very anti-inflammatory, so they reduce inflammation in our body, but especially in our blood vessels. And many people might have heard of atheroma, which is a build-up of a fatty deposit lining the blood vessels. And when this becomes thicker, then the blood flow through that area of thickening is less, and then if there's a small clot that occurs on it, that can dislodge, and that's when people can have a heart attack, because the little clot can occur in a narrowed blood vessel, and the blood vessels affecting our hearts are quite narrow as well. So anything we want to do is to keep our blood vessels open so the blood can go in very easily. The blood contains oxygen in our arteries, which gives us all our nutrients as well as oxygen to all our cells. So it's really important that our heart and our cardiovascular system are as healthy as possible. So estrogen can help reduce any inflammation, reduce this atheroma, reduce this fatty deposit, and also it can help relax the blood vessels so they become wider and calmer, if you like, and then that actually can help lower blood pressure as well. So our hormones have lots of effects. They reduce this atheroma, they can lower blood pressure, they can also reduce any future heart disease, and also they work together in a really good balance, which is really important to know. We don't know whether it's worse when people are in the perimenopause, when their hormone levels fluctuate, or when hormone levels are low. And we often find that symptoms are worse during the perimenopause compared to the menopause. But we do know when estrogen levels are low, and they can continue to be low in the menopause, that's when this increased incidence of cardiovascular disease occurs. And we've known for many years that the longer a woman is without her hormones, the greater the risk of cardiovascular disease. So women who have an earlier menopause, as Rebecca says, about 3 in 100, it might even be more, of women under the age of 40 have an early menopause. If those women aren't given HRT, then they have an increased risk of heart disease, don't they?
Oh yes, it increases 5-fold after the menopause, in fact. And you're absolutely right, it's lower. We have these lovely hormones that protect our hearts, just as Louise was saying. So after the menopause, when we lose these hormones, if you look at a graph, we're very low risk of heart disease, perhaps in our 30s and 40s, but after 50, it suddenly goes up really steeply and actually overtakes men. We have a higher risk of heart disease in the menopause and the postmenopause. And the problem is our symptoms of heart attacks are often very different from the men's symptoms of heart attacks. So not only do we have a higher risk of heart disease after the menopause, if we do have a heart attack, it's often not recognised because it's not necessarily the classical symptoms. So women often feel nauseated or have pain in the back as well as the front, and pain radiating up into the jaw. These sort of things which are slightly different from men's versions of the heart attack. So it can take longer for a woman having a heart attack to get the right diagnosis quickly and promptly and get access to the correct treatment promptly, which is vital once someone's had a heart attack.
It's really important, isn't it? And we do know that the prognosis for a woman who's had a heart attack is actually worse than a man. That might be because, like you say, that people present later or they're misdiagnosed. Many people have seen in films a person having a heart attack, they're clutching at their chest, they get this sort of elephant feeling sitting on their chest, sometimes radiating down their arm or up to their jaw, looking quite pale and clammy. But that doesn't always happen in women, and so therefore it can be quite hard sometimes to diagnose if someone's having a heart attack. And often people don't expect women to have heart attacks, but they do.
They do.
And it's really important actually to be checked out if you think you might be experiencing symptoms, even sometimes just some shortness of breath that comes on without realising, without any other reason. Then that can sometimes be a sign or an indication that your heart's not working as well. The other thing that increases risk of a heart attack is actually having raised cholesterol. So cholesterol is a very interesting thing. Cholesterol, everyone thinks is bad, and actually cholesterol is quite good. Cholesterol forms the cell membranes. We all have cells in our body, and they're made from cholesterol. And also, all our hormones are made from cholesterol. From the pathways that happen, cholesterol is broken down with different enzymes to estrogen, progesterone and testosterone. So if we have no cholesterol in our body at all, we actually can't function very well as humans. But there are good and bad cholesterols as well, and our liver works really hard to produce the right type of cholesterol for us. But the bad cholesterol, which is the low density lipoprotein LDL cholesterol, actually has been shown to be associated with increased risk of heart disease. And many people will have heard of a drug called statins. So there's different statins. There's ones like simvastatin, atorvastatin, lipostatin, that can reduce our cholesterol. Now, the studies have mainly been done in men because all research is done in men, isn't it? And with men, we know that people who have a statin have a lower risk in the future of a heart attack. And certainly if someone's had a heart attack, it can reduce the risk of another heart attack, which is really good. In women, actually, the studies are not as robust and they haven't been done as well. We know that probably if someone's had a heart attack as a woman, taking a statin is a good idea, reduces the risk of a heart attack in the future. But there isn't really good, solid evidence that women who haven't had a heart attack but have raised cholesterol actually benefit from taking a statin. But if we look at the evidence for women using HRT to reduce risk from heart disease and heart attacks, it's actually very good. And if if you group the studies together, it shows that there is a reduction in heart attacks from women who take HRT by about 50%, which is a lot when it's such a common condition. And also the studies have shown that taking HRT can reduce mortality, so death from a heart attack, by about 30%. So that is a lot, far better than any statin medication or even blood pressure lowering treatments.
Far superior, but it's been neglected, of course. And it's so awful, because not only does it reduce our risk, but it will treat all our symptoms.
Yes.
So, for free, it's the best medication I've ever prescribed, because not only does it make my patient feel better and resolve their symptoms very often so they feel back to themselves, it will halve their risk if taken within 10 years of their last period. It will halve their risk of heart disease, reduce their risk of osteoporosis, type 2 diabetes, and many other things as well. It's so universally beneficial for women. Certainly by decreasing the heart disease by 50% is an amazing figure, and it improves the cholesterol profile, so it actually favours the good cholesterol and tries to keep the bad cholesterol, the LDL cholesterol, down, doesn't it? And as well, the effects on glucose as well.
Absolutely. We see a lot of people in the clinic who have their cholesterol levels measured and then every year have it repeated, and you see that their bad cholesterol, their LDL cholesterol, will reduce, but also their good cholesterol, their HDL cholesterol, can increase just with taking hormones. And it's often under recognised, actually, the role of hormones. We know from the evidence that taking HRT in the perimenopause or within 10 years of the menopause is the most beneficial time when we're thinking about reducing risk of cardiovascular disease. Now, some people might have heard that it's not safe, or it could increase risk of a heart attack if given over the age of 60 or beyond 10 years from the menopause. Now, that actually harks back to the WHI study, the Women's Health Initiative study, which was the study that really put a nail in the coffin for HRT. It was produced over 20 years ago now, and it was the headline news that HRT causes breast cancer. Now, as many of you hopefully know who are watching, we know that from the study, when the data was looked at properly, this increased risk of breast cancer wasn't statistically significant and actually was very low compared to other lifestyle risk factors for breast cancer, such as drinking alcohol, not exercising, or being overweight. And they looked at different types of HRT to what we prescribe now. They also showed in the study that women who started HRT within 10 years of their menopause had a lower future risk of heart disease. But they showed that if they started over the 10 years, so in their 60s, a few women had an increased risk of heart disease. What they didn't tell us then was a lot of those women did have heart disease in their past history. So a lot of them had had heart attacks, raised blood pressure, they were obese. And also the type of HRT they were given, we know does have a small heart disease risk with it, because it was a synthetic progesterone, which we don't usually prescribe now. So fast forward 20 years, we usually prescribe body identical hormones, so the same hormone as what we produce when we're younger, but also the estrogen goes through the skin, so there's no risk of clot either. So we don't have big studies showing benefits starting HRT in women over the age of 60, but we also don't have studies to show that it's harmful. We also know, just from looking at the molecular basis of how estrogen works in our body and how anti-inflammatory it is, and how, like we said, it can reduce blood pressure too, it doesn't make sort of physiological sense to deny people hormones just based on their age, does it?
No, it doesn't. And people still have symptoms. I've got patients who are in their 90s still having symptoms. Now, some symptoms will abate, but not the case for everybody. Symptoms can go on for decades. And we know that HRT is the best treatment for these symptoms. So if you're on your mid-60s and suffering, then it would be perfectly reasonable, really, after an individualised consultation, perhaps to end up starting on a low dose of HRT and building up your requirements according to you, the individual. it will help symptoms. It will always treat osteoporosis or help prevent osteoporosis and help improve bone density at any age that it started. Even if someone in their 90s, if they were to start HRT, their bone density has shown to always improve with that. And I think using low dose, just as Louise has said, this is a game changer. The new type of HRT is so beneficial for the cardiovascular system. It gently dilates the arteries so that the blood flow can keep going. So actually, it doesn't mean you can't have HRT just because you're over the age of 60.
Yeah, and that's really important to know, isn't it? You wouldn't have the older types of HRT, but we don't really prescribe them to younger people either. No. But there are benefits, and we see that in our patients. And often in people who are older, we start the HRT in a very low dose and then just gradually increase according to how symptoms are. And it is likely to be beneficial for the heart, but as you say, it's very beneficial for bones as well. And actually to improve symptoms, a lot of people say they feel much better, have more energy, and often things like muscle and joint pains can improve. Even passing urine, a lot of older people say, oh, well, I get up 3 or 4 times in the night, and they think that's just because they're older. They don't realise it's related to their hormones, and just being able to sleep a bit better, not going to the toilet so often, not having muscle and joint pains every time you get out of bed can be quite transformational for many older women, can't it?
So important. We know now how important sleep is anyway. Yeah. So if you can improve sleep, you're already helping your cardiovascular risk by just that modality, really. But yes, hugely beneficial.
Yeah, and a few people, we've had some great questions, so thanks for those. And if you've got any others, you can still ask us questions. People have asked about what are the treatments in addition to HRT or instead of HRT. Now, we have to be really careful when we think about HRT or not HRT or alternative treatments. When people take HRT, it's still really important to look at the bigger picture. It's really important to look holistically at lifestyle. So whether we take HRT or not, it's really essential, isn't it, to look at our nutrition and exercise, everything else.
Totally. A really good lifestyle will help your cardiovascular risk. We know that. Eating a really healthy diet, making sure the weight's in the normal range, not getting overweight, exercising regularly, 75 minutes of quite high impact cardiovascular exercise a week, or 150 minutes of perhaps a lower level of exercise, one or the other, whatever is preferable to the individual, but keeping moving, avoiding sedentary sort of behaviour, which unfortunately is really common now in our lifestyle. We're always at a desk on a computer or that sort of thing, and this is a real problem. But actually keeping moving and exercising is really vitally important. Making sure we're not drinking too much alcohol. If we're smoking, again, to stop doing that. And the form of exercise, as well as cardiovascular exercise, actually is weight-bearing exercise and doing weights and using your body weight for exercise, because that will help your bone density a little bit as well. So all these sort of things are all very important to be thought of in a whole, in a holistic way.
It's really important, and what we can get away with eating when we're in our teenagers, we often can't get away with eating when we're older, but we still need to be it's really important to think about how our diet can affect our heart health as well, and actually our blood pressure as well. And we know, eating processed foods is not so good for us. Eating foods high in sugar are not so good for us. Ultra processed foods are the worst because they are chemicals really in our body, and our bodies don't know how to utilize them properly. So we do know there's an increased risk of heart disease with people who eat certain foods, but also obesity, type 2 diabetes. This sort of metabolic processes that occur can really change, and that will push up risk for cardiovascular disease as well. So taking things back to quite basic foods, really, foods that we recognise, fresh fruit, vegetables. Oils are still good, fats are really good, but it's far better to have fat in an avocado than it is fat in some chips that have been bought from a takeaway, for example. So it's really important to look at what we're eating, isn't it?
Yeah, totally.
And not just counting calories. And lots of people who've had heart disease, and certainly it used to be recommended when I was doing a cardiology job that people should have low-fat diets. And anything actually that's labelled low-fat should actually go in the bin or not be bought, because what low-fat food does is it's often enhanced with more sugars to increase the taste, and it doesn't fill people up. So for example, if you're going to have a yogurt, make sure it's a full-fat yogurt rather than a low-fat yogurt. Or even milk, you know, full-fat milk is only 4% fat, but it has more of the fat-soluble vitamins. A, D, E and K are our fat-soluble vitamins, and they're impossible to get if we don't have fat. So fat can be really good as long as it's healthy fat.
Completely agree, yeah. I mean, eating from the soil really is the mantra, isn't it?
Yes.
And avoiding the ultra-processed food is incredibly important.
So someone said, how do I know if my heart palpitations are due to anxiety or the menopause? Well, we don't often know, do we?
No, we don't. And low estrogen levels will cause anxiety. They're so interlinked, really. So if someone, for example, has another symptom and they're feeling anxious and low because they've had a recent bereavement, they've got other symptoms of the menopause. Their periods are changing, they're perhaps having some flushes and sweats, their muscle and joints are sore and aching, they're fatigued, they're not sleeping. You know, we treat the menopause anyway with their hormones, and we see what gets better, and often they find that their anxiety gets better and the palpitations therefore improve as well. So I think it's making the diagnosis of perimenopause and menopause and giving correct treatment with HRT and optimizing that treatment and seeing what falls away. And very often the anxiety improves once you treat the menopause.
And we spend a lot of time, don't we, in the clinic, making sure people have their hormones balanced. So about a third of women who come to our clinic, Newson Health Clinic, actually are already on HRT, but they're not on the right dose or type for them. And it's not just estrogen. I know we've talked a lot about estrogen, but actually progesterone can affect the heart and testosterone. And we've seen from some of our data that palpitations can improve with testosterone as well. And testosterone hasn't really been looked at very closely with heart disease, especially in women. It has more with men. A big study came out over a year now ago showing that women who had low testosterone levels have a higher incidence of cardiovascular disease. We don't know whether replacing that will lower the risk, but common sense will tell us it probably does, because again, testosterone is very beneficial for men. We know that if men have low testosterone and have their testosterone replaced, their incidence of heart disease reduces. It's very likely to be the same because we've got testosterone receptors in our cardiovascular system too. So in the clinic, we spend a lot of time optimizing hormones, making sure estrogen, progesterone, testosterone are balanced, that people are on the right dose, the right amount for them at that particular time. So doses might need to be changed. And then we see how symptoms melt away. Because if someone has their hormones rebalanced and they're still having palpitations, then it is likely that their palpitations are not due to their hormones.
That's right.
And people are allowed to have more than one disease in medicine, and I'm not saying necessarily that the menopause is a disease, but if someone does have a heart condition, it doesn't mean they can't have HRT. They can still have treatment for their heart condition, be investigated for it, but in parallel can still usually take HRT.
Yeah, that's right. I think there was a question about that actually. I've got a heart problem, can I take HRT? Well, yes, actually, because it is very beneficial for the heart. But it's important to take the right type of HRT, isn't it?
Yes.
As we were saying earlier, estrogen through the regulated body identical HRT, where estrogen is given through the skin, and body identical progesterone. We wouldn't use the old-fashioned tablet estrogen and progesterone. It's not so healthy for the heart.
Yeah, so the main concern also is these older types of progesterone, the progestogens, that we used to use in the old days, if you like, they do seem to have a small increased risk of cardiovascular disease with them, and also they can sort of negate the good effects of estrogen in the body. So where possible, we try to convert people to the estrogen through the skin so it stays as the natural estrogen, and also the natural progesterone, which is called a micronized progesterone, and it's usually taken orally. Or some people have the Mirena coil, which does contain the synthetic progesterone, but it's a very low dose, isn't it?
Very low dose, and hardly anything really gets into the bloodstream. The first 3 months after insertion, a small amount might get in, but after that it's really very low amounts. So
yes.
A good thing to have to protect the womb.
So it won't be associated with a risk of
No, it
heart
won't.
disease
It
at
won't.
all.
Even though it's a synthetic one,
Yeah.
it won't. It's not the same as taking a tablet of the synthetic progesterone.
No. Someone said, I have an underactive thyroid. How do I know if my palpitations are due to that or low estrogen? And like we've said before, it's actually very hard to know. It's usually an overactive thyroid that people have palpitations rather than underactive. But often you can do thyroid blood tests to see what the level of thyroxine hormone is in the bloodstream, and if sometimes people need to have thyroxine or thyroid hormones as well as HRT. All our hormones work very closely together in our body. They don't work in isolation. So often when people are perimenopausal or menopausal and their estrogen levels are low, it can put a strain on thyroid hormones. So we often see people who have what we call borderline thyroid disorder. So their thyroid function test is slightly off, but not off bad enough to necessarily rush and start treatment. And we often find once people have HRT, then their thyroid function improves. Because if you don't have estrogen in an adequate amount in the body, your body thinks, right, how do I get hold of this estrogen? I really need it. And it will try and sort of see if the thyroxine will do some of the jobs of the estrogen, and it puts a strain on the thyroid gland. So it's very important sometimes to treat one thing and then see how everything else sort of settles together, don't we?
Yeah, exactly. Two things can occur, but often when you get the hormones balanced, it's amazing how many symptoms melt away.
So when people have palpitations, this fluttering in the heart, and we give HRT, it can really vary how quickly it takes for the palpitations to improve. I've seen quite a few patients who have literally said within days their palpitations melt away. But other people, it can take 3 months or so. And we always say when we start HRT, wait for 3 months before adjusting the dose or reviewing to see whether it suited you or not. Because some people, it can take quite a long time, can't it?
Yeah, be patient with it, because it may take 3 months. There may be issues that you're not absorbing very well through the skin, so need to increase the dose. You may need to add in testosterone to help symptoms. There are all sorts of things we can do, so it's not a one dose fits all. It's really important to get that across. You know, the doses will vary from person to person, so you won't be on the same dose as your friend or your sister. It will be a unique dose to you, because that's really important. We know that. It's about individualising the treatment to the patient. That's very, very important. There's a huge variation in how we absorb through the skin, a tenfold variation. So some people are very efficient at absorbing estrogen through the skin, and others aren't, so need a higher dose to get the right blood therapeutic levels within the body.
And that's important. So if your symptoms aren't improving and your doctor or your clinician thinks your symptoms are related to your changing hormone levels, then it's always worth making an appointment to see if the dose needs adjusting or the type needs adjusting. And certainly when we start hormones in the perimenopause, as Rebecca's already said, the hormone levels fluctuate so much that often people start on a smaller dose and then need to increase as their normal hormones in their body reduce further as they become menopausal. Sometimes when people are perimenopausal, they have such great hormonal swings that we actually give a higher level to try and suppress their own hormones sort of fluctuating. Because when our hormone levels are smoother, then often people feel a lot better, because it's not just our brain but our bodies like things very stable, and so that's when people can feel worse, when their hormone levels can fluctuate. And the same with the heart. The heart likes everything chemically stable as well, and if there's some instability, especially around the cardiovascular system and the conducting system of the heart, that can then trigger different sort of arrhythmias, which is abnormal palpitations and heart tracing. And although we've said a lot of palpitations are benign, as in they're not associated with heart disease, we do know there's a condition called atrial fibrillation, where the heart becomes irregular, and when the heart doesn't beat regularly, it doesn't pump in the same way, so it's not so efficient of pumping blood around the body. And we do know from studies that the longer a woman is without her hormones, especially women who have an early menopause or POI, there's an increased incidence of atrial fibrillation as well. And also heart failure, which is where the heart generally doesn't pump as well. The muscle of the heart is affected, doesn't pump as well, so then it doesn't circulate blood so well throughout the body, and people often feel quite short of breath, and with that sometimes have swollen ankles. And again, the longer a woman is out without her hormones, the greater the incidence, which does really tell us that hormones are very important with the whole way our hearts work. So not just within the blood vessels, as I've explained before, not just within the conducting system, but also in the muscle of the heart as well. You know, the heart is a big muscle that we really need, and it's so important to look after. And if we don't have our hormones, it can really have an effect. And for too long, really, we've neglected our hearts when it comes to hormonal health. We've all talked about this increased incidence of cardiovascular disease. Lots of people have skirted around the issue about, well, if there's a longer incident or a longer time without hormones, increasing risk of cardiovascular disease, they're not sort of putting the next step in, thinking, well, if we replace those hormones, does it reduce risk? And we do have studies now, and we have enough studies to safely say that there is enough evidence to reduce the risk of cardiovascular disease with taking HRT. And that's really important for people to know, because there's been so much uncertainty. And actually, even if you open the insert, so the patches and gels, they all have the inserts with patient information in them. And if you open it, it will say increased risk of heart disease, which is absolutely wrong, because there isn't this increased risk. And even vaginal hormonal preparations, which we use for symptoms related to vaginal dryness, soreness, urinary symptoms, it will even say in that insert, increased risk of heart disease. Well, these hormones, when they're used in the vagina, are very, very low dose anyway, and they don't get into the whole circulation. So it's impossible to increase risk of heart disease. So it's very important that you're not reading the wrong information, which is going to make you probably and quite understandably concerned. It's really important to think about the hormones that we're having, especially when they're body identical, how important they are as biologically active hormones in our body. Would you agree with that?
I totally agree with that. It's amazing how these studies have been done, showing a halving of risk. Now, you know, much better than a statin, but it hasn't reached the consciousness of women or healthcare professionals, sadly. So we're telling you now that it's better, if it starts within 10 years, HRT is better than a statin in preventing heart disease. So.
Yeah. Now, someone's asked, can I ask my cardiologist for testosterone to improve my exercise tolerance and stamina? Of course, you can ask your cardiologist for anything. What we don't know is what your cardiologist will say with that. And testosterone is a very interesting hormone. It's a biologically active hormone. In fact, more active when we're younger than any other hormone in our body. Yet, for many years, we've just been hoodwinked, really, and told, well, testosterone's for the boys, estrogen's for the girls. It's not actually true, because we have cells that respond to testosterone all around our body. So we've already said in our cardiovascular system, but also in our brain and our muscles and our joints. At the moment, the guidelines all say that we can prescribe testosterone for reduced libido. And many women have reduced libido during the perimenopause and menopause. But we know from our our clinical experience and experience from many other menopause specialists all over the world actually, that women who take testosterone find that their mood, energy, concentration and stamina can improve as well. Often their mental health, their pleasure in life can really be elevated with testosterone. And again, that's no surprise if you look at how testosterone works in our brains. It works as a neurotransmitter. So it works as a chemical really in our brain that tells other cells in our brain how to function, and it can also interfere and react with other hormones in our brain such as serotonin, our happy hormone, dopamine, our reward hormone, and it lights up areas in our brain as well. So it can improve stamina, it can improve mood as well. There has always been this concern that if you have too much, it could increase risk of heart disease, and certainly in men it might do, but you have to have quite high levels. In women we prescribe very low doses just to replace the missing amount. So there's not a study that shows there's an increased risk of heart disease with testosterone, is there?
No, there's not. No.
So I think with time, if the studies are done, which they haven't been done and hopefully they will be done, we can show that women who take testosterone have a lower risk of heart disease. Very difficult to prove because we don't have funding for really good quality studies. But we do know, and certainly from our patients who use testosterone, because they've got more energy, they've got more stamina, they can exercise more, and they often are more motivated to cook better, to eat better, and actually sleep can really improve with testosterone. So we know that poor quality sleep increases risk of cardiovascular disease. We know not exercising well increases risk of cardiovascular disease. We know not eating well increases risk of cardiovascular disease. So taking testosterone might reduce risk just from improving lifestyle, as well as possibly having this direct effect as well. So it's really important that we're looking at people in a very holistic way. The problem is with a lot of things in medicine, there's no joined up thinking. So the cardiologist will just think about the heart, the neurologist will just think about the brain, whereas our hormones go in our heart, of course, they go in our brain, they go everywhere. But unfortunately, a lot of cardiologists aren't taught about the menopause, or neurologists or other specialties, which makes it very disjointing for women when they're trying to receive treatment.
It does actually. It's lack of joined up thinking, and now we've become such experts. We practice in these silos of expertise, and as Louise said, that they've become super experts in a certain area, and really menopause they haven't been taught about menopause, so it doesn't enter the equation at all really. Well, it should be on everyone's lips really as a differential diagnosis for so many specialities, migraines, urology, recurrent urinary tract infections, recurrent urinary or bladder problems, migraines, joint and muscle problems. So a lot of people are diagnosed with fibromyalgia, and we find when their hormones are corrected, that all goes away and they can stop their medications. Psychiatry as well, how impactful our hormones are on our mental health. So it's all of us together, working together. And actually, as the woman in the middle of it, if a woman is empowered and understands their symptoms and thinks, actually, I think all these symptoms are one common thing, could it be my hormones? That can really help get the conversation off to a good start and help people find the right treatment for you.
Absolutely. I think as much information as possible that you get, and you can simulate it and really go to your healthcare professional saying, I've read this, I understand this, this is what I'd like to talk about, and I would really like to talk about my treatment options. So making the diagnosis yourself is actually really important as well. So we've had a few questions about blood pressure. Blood pressure can often confuse people, like, what is it? Why do we get blood pressure? Do we need blood pressure? And a lot of people talk about blood pressure as a disorder, but it's actually only when it's raised. The other word for it is hypertension. And we know that when people have raised blood pressure, so hypertension, for many years, the longer they have it, the greater the risk of heart disease, because it puts more strain on the heart. So how would you describe what raised blood pressure, or what blood pressure even is?
Yes, it's a tube, and it's the pressure within that tube. The tube being the arteries or the vessels, and it should run at a certain level, about 120/80 on average. But if the vessel walls get tighter and are less elastic, and that can happen when we lose estrogen, it helps the elasticity of the wall. So if it becomes more of a rigid structure, you can imagine this is how the pressure can rise within the system. So it's really about the blood vessels, how they're reacting and how stiff they are, I think would be a good way to explain it. And the stiffer and more inflexible they become, the blood pressure rises. There are lots of hormones, renin and aldosterone are hormones that also act on the vessels that cause the constriction, or not only being rigid, becomes smaller in diameter. So if the diameter of the artery, which starts out quite nice and big and relaxed, becomes stiffer, not only the walls are stiffer, but the diameter gets smaller and smaller, then the pressure inside really goes up, and this is a huge risk factor for heart attacks and stroke, as well as other areas of our body. So problems with the kidney, renal failure as well, due to high blood pressure. So it's important to get that pressure right and in the normal range. And we know that estrogen will cause relaxation and dilation of the vessels. So we'll actually, if estrogen is given through the skin, this type of estrogen will help reduce blood pressure to a certain extent, or certainly shouldn't increase it at all.
And most people with hypertension or raised blood pressure don't have any symptoms. Sometimes people can feel a bit more tired or have some headaches, so it's usually worth having your blood pressure checked regularly. And many people now, you can just buy them, not the ones around the wrist, but around the upper arm is a cuff, and you literally press a button and it will give you a reading. There's a top reading and a bottom reading, and it's that both readings are really important to see. Now, blood pressure raises as we get older, so the older we are, the more likely we are to have raised blood pressure. Raised blood pressure can sometimes run in families. It can be associated with other conditions sometimes, and certainly if someone's young and has raised blood pressure, we often do other investigations to see. But we know that the menopause causes raised blood pressure. Obviously, it causes lots of conditions. So the longer a woman is without hormones, the greater the risk of raised blood pressure. Now, in the past, people used to say you can't start HRT if you've got raised blood pressure, and that was right for the older types of HRT. Now, with the body identical hormones, actually, it is usually safe to give HRT if someone's got raised blood pressure, and the guidelines are clear that we can still. Some women do need blood pressure lowering treatment as well as HRT, and it's very safe to use these together. Some people find, and there was a question earlier about my blood pressure's gone up with starting HRT, why is this? Well, it might be that you've been given a synthetic, an older type of HRT, and that can raise blood pressure. Or it might be that your blood pressure's gone up anyway and it's not related to your HRT, it's just a coincidence. And so usually we would continue with the HRT, making sure the estrogen's through the skin, the natural progesterone is on the right dose, and if the blood pressure continues, then adding in a blood pressure lowering treatment. But it's not usually advised to stop taking HRT. And we actually know from some studies that women who stop taking HRT in their first year have an increased risk of heart disease as well. Most women can carry on taking HRT forever, can't they?
Yeah, I mean, how long one goes on taking HRT is down to the individual, really. We always say you must have an annual review, and then you and your clinician can decide whether the benefits of continuing with HRT outweigh the risks. So if a woman has found it beneficial and wishes to continue, and it seems very safe, there's no reason to stop it.
Absolutely, because we take HRT to improve symptoms. Of course, it's lovely to feel better, but also looking at our future disease risk as well. And so as soon as someone stops taking HRT, their risk of diseases increases, especially osteoporosis as we get older, but also, like I've already said, heart disease as well. So it's important to think, do I really want to stop my HRT? Maybe the dose needs changing, but usually people can continue taking it for forever. Usually we say people have an annual review to make sure everything's all right. And a lot of guidelines do say people should have blood pressure taken annually. But actually that's not really as they're worried about the HRT. It's more just as a general check, isn't it, to make sure.
Yes, it's a general sensible thing to do when a woman reaches a certain age, and men. We should have an annual check, but it's not because of the HRT or the new types of HRT. As we said, it doesn't increase your blood pressure.
No.
So it's not because of that.
Yeah. So we've covered quite a lot actually in a short space of time. So just to recap really, our menopause and perimenopause is thinking about our hormones being fluctuating in the perimenopause, low in the menopause, how our hormones, estrogen, progesterone and testosterone go all around our body, but especially in our heart and our cardiovascular system as well, and really work to reduce our risk of heart disease. So younger women who have hormones have a lower risk of heart disease than older women without their hormones. And the misinformation that has occurred for 20 years plus pushing women away from HRT has actually sadly increased incidence of cardiovascular disease, not just in the UK but worldwide as well. So we now need to be spinning things on the head a bit more and thinking about HRT for disease prevention. Sadly, some of the guidelines say there isn't enough evidence, but actually there is enough evidence. People are scared of suggesting it because certainly in America, if they say there was enough evidence, it would affect insurance and people would have to have insurance for the menopause, which no one would want because it's 51% of the population. So we don't need to think about the politics, we need to think about the science. And there is plenty of science and evidence that taking HRT reduces risk of cardiovascular disease. So we really need to be thinking about why are we not taking HRT? What are the risks of not taking HRT rather than the risks of taking HRT? Because for most women, there aren't risks of taking body identical HRT. But without hormones, we've already said quite a few times that there is this increased risk of cardiovascular disease. And when cardiovascular disease is so common, and actually deaths from cardiovascular disease are so common as well, we really need to be addressing this in a very proactive way. So thinking about HRT, having the right dose and type, thinking about nutrition, thinking about exercise, thinking about sleep, thinking about well-being. All of these are really, really important when we want to invest in our future health.
Completely agree. Couldn't have put it better.
So thank you so much for joining us tonight on World Menopause Day. It's a very exciting day, but actually we have to remember that it is just a day, and every day there are menopausal women, and every day there are women that are suffering, and every day there are women who are unable to receive evidence-based advice, support and treatment. And if you are one of these people, then make sure that this changes for you. So download the free Balance app, get some more information, look at any symptoms you have, seek help from a healthcare professional, and if you don't seek help from the right healthcare professional the first time, then you are entitled to see someone else and really try and get the help, support and treatment that you need and deserve, not just to improve your symptoms, but to invest in your future health. So thank you so much for joining us today, and good luck and keep healthy.